Hello and welcome back to Farm Fundamentals. Today we begin our deep dive into the pathogenesis of acute inflammation, focusing on the earliest and most critical element, the vascular changes. So this phase is the logistical bottleneck of the entire inflammatory response. It dictates the delivery of vital plasma proteins and cellular components to the site of pathology, fundamentally governing the subsequent cellular response. So, our session today over here focuses on the hemodynamic and permeability alterations that defines this earlier stage. By this end, you should be precisely able to delineate the three-stage sequence, understand the differential effects on various microvascular segments, and correlate these pathophysiological processes directly with the cardinal clinical signs we observe bedside. So let's get into this. The vascular response unfolds in a precise triphasic hemodynamic sequence. So this is the change in blood flow mechanics at the microcirculatory level. We have three stages, as I've told: transient vasoconstriction. So this is a fleeting minimal response. It's immediate within seconds and primarily involves arterioles. It's mediated by a local neurogenic reflex and release of potent local vasoconstrictors like endothelin. Crucially, it lasts only for a few seconds or a maximum of few minutes and often holds negligible clinical significance. Its primary purpose is like a brief restriction to hemorrhage following trauma. And the second stage over here is arteriolar and capillary vasodilation. That's the primary response. Following the brief period of constriction, we observe the rapid and sustained vasodilation. This is the first major influential change. The dilation is triggered by a potent cocktail of chemical mediators released locally. As in histamine, it's released from the activated mast cells and basophils. Nitric oxide, a potential endothelial-derived relaxing factor, and prostaglandins, especially PGE2 and PGI2. So, this vasodilation results in a massive increase in local blood flow, a state known as hyperemia. So, this increased flow is directly responsible for two of the cardinal signs of inflammation, rubor and calor, due to the influx of warm arterial blood. And the final stage is stasis and hemoconcentration. It's preparation for the cellular events, basically. As the vessels dilate and crucially become more permeable, the net loss of plasma fluid into the extravascular space drastically increases the blood viscosity. This increased viscosity, coupled with the dilated microvasculature, leads to stasis, a marked slowing or cessation of blood flow. This allows for physical segregation of blood components. The heavier cellular elements, particularly the leukocytes, are pushed out of the central axial flow column and fall towards the endothelial lining. This process is known as margination and it sets the physical conditions for cellular phase of inflammation. Increased permeability, the mechanisms of exudation. That's what we see here. So, this is the hallmark of inflammation. The dramatic increase in permeability allows the escape of high molecular weight proteins, um, notably fibrinogen and immunoglobulins, into the interstitium. So, this distinguishes the protein rich exudate from a simple transudate. We must understand five major mechanisms I have given here. So the first one is endothelial cell contraction. This is the most common mechanism mediated by fast-acting molecules like histamine, bradykinin, and leukotrienes. These mediators bind with specific receptors, including cytoskeletal reorganization within the endothelial cells, forming a transient interendothelial grafts. Critically, this occurs almost exclusively in venules and it's rapid but short lived. It occurs in venules, so yeah, everything is over here. And the next one we see over here, the next mechanism is direct endothelial injury. So here, severe stimuli such as high-grade thermal burns, direct bacterial toxins, or gamma radiation cause direct necrosis and physical detachment of the endothelial cells. So the time course over here is immediate, sustained, hours to days. The vessels affected are arterioles, capillaries, and venules. Endothelial necrosis and detachment is seen. Leakage is immediate and prolonged until the vessel thrombosis is on repair. Then the third mechanism is leukocyte-dependent injury. So this mechanism is responsible for the delayed and prolonged phase of leakage. As leukocytes are there, they release toxic oxygen species like superoxide and proteolytic enzymes like elastase to clear the infection. Uncontrolled release can cause significant bystander injury to the underlying endothelium, creating larger, long-lasting defects. And it primarily affects the venule. Right, and the next mechanism is our increased transcytosis. Some mediators notably are VEGF, that's vascular endothelial growth factor, stimulate an increased number and size of endothelial vesicles and vacuoles, creating transient transport channels across the cell cytoplasm. This is sometimes referred to as formation of vesiculovascular organelles, and it's sustained venules are mostly affected. And yeah, next type, that's the final type, is our leakage from regenerating endothelium. During the repair phase, the newly synthesized endothelium is often immature and structurally leaky, providing a temporary path for fluid escape. The mediator over here is unknown, the time course is delayed, capillaries are majorly affected, and it occurs during repair. Incomplete healing allows temporary leakage. So next we speak about hydrodynamic changes. Understanding the physics of fluid exchange is essential. The movement of fluid is governed by Starling forces, hydrostatic force, and oncotic pressure. So transduate, it's the non-inflammatory edema. In transduate, the endothelium is intact. The problem is the hemodynamic imbalance. For example, in heart failure, increased venous pressure elevates the capillary pressure, the pushing force. So the plasma proteins are retained. This results in low protein content and low specific gravity. So the fluid over here is with these features. The second type is our exudate, inflammatory edema. Exudate is the product of inflammation. The primary event is the loss of endothelial integrity, increased permeability. This allows the massive escape of protein, which lowers the intravascular and increases the interstitial osmolarity, driving more fluid out. This results in a fluid with high protein content, high specific gravity. Crucially, it contains a high level of fibrinogen and active anti-inflammatory cells. So to consolidate, we integrate these physiological changes into clinical picture. The sequence moves from vasodilation, giving us rubor and calor, to increase permeability, driving the exudation, to stasis, facilitating margination. So tumor. So this is directly the it's solely attributable to the accumulation of protein-rich exudate in the interstitial space. Dolor, partially caused by physical stretching and increased hydrostatic pressure from the exudate compressing nerve endings, and primarily mediated by chemical action of mediators like bradykinin and prostaglandins. The fibrin barrier, the escape fibrinogen, converts fibrin in the tissue. So this creates a physical mesh, a fibrin network that serves two functions: preventing the systemic spread of infectious agent and providing a scaffold for the later infiltration of the repair cells. So the vascular phase is not merely a sign of injury, but an active, indispensable mechanism for initiating defense and repair. Understanding these differential forces and molecular events is key to understanding the pharmacology of anti-inflammatory drugs. So that's it for this session. Until the next one, keep studying and keep revising.